Epilepsy surgery has a reputation for being the hardest functional topic in the exam. It isn't. It's just long. So we've split it the way a real case is worked up. Diagnose, investigate, operate. Part 1 is diagnosis. How you define, localize, and recognize the epilepsy before anyone talks about surgery. Keep the spine in your head for every epilepsy question. Define the epilepsy, localize the focus from the story, recognize the syndrome, investigate, then operate. This video owns the first stretch, 4 ideas. The definitions, seizure, semiology, and localization, the name syndromes, and the EEG. Get these right, and the surgical parts become easy. First idea, definitions, and the exam loves exact thresholds. Epilepsy is not one seizure. It's an enduring tendency to recurrent, unprovoked seizures, generally 2 or more than 24 hours apart. When you classify, the very first branch point is onset, focal, generalized, or unknown, not cause, not age, and the number that unlocks surgery. Epilepsy is drug resistant when 2 appropriately chosen, tolerated drugs have failed. 2 seizures to diagnose, 2 drugs to refer. That pair is worth a mark on its own. B. Epilepsy is the enduring predisposition to unprovoked seizures. A single seizure or a provoked one is not epilepsy. C. Onset is the first branch. Focal seizures are then subdivided by awareness and by motor or non-motor features. B. Idiopathic or genetic. Juvenile myoclonic epilepsy has a presumed genetic basis and no structural lesion. B. Failure of 2 adequate, tolerated antiepileptic drugs to achieve sustained seizure freedom. That's the definition that triggers a surgical referral. Second idea, semiology, the free localization tool. The clinical sequence lateralizes and localizes the focus before any scan. Learn the fingerprints. Temporal, a rising epigastric aura and déjà vu. Then lip smacking and fumbling automatisms, and a long, confused recovery. Frontal, short, frequent, often nighttime attacks with wild hypermotor posturing and a fast recovery. Occipital, simple flashing lights in the opposite visual field. And a post-ictal weakness lasting up to about 36 hours is Todd's paralysis. A lateralizing clue, not a stroke. B. The clinical sequence is a cheap, powerful way to lateralize and localize the focus, alongside the EEG and imaging. C. Aura, oroelementary, and manual automatisms. And long post-ictal confusion is the classic temporal lobe picture. B. Frontal seizures are short, clustered, often nocturnal, with prominent complex motor activity and a quick recovery. C. Occipital seizures produce simple visual phenomena in the opposite hemifield. B. Todd's paralysis, a post-ictal self-limiting deficit, and a lateralizing clue, not a stroke. Third idea, the named syndromes, and the shortcut is the EEG frequency. 3 Hz spike and wave is absence. Slow spike and wave, 1.5 to 2.5 Hz, with multiple seizure types and drop attacks, is Lennox-Gastaut. Remember the drop attacks because they're the classic reason to do a corpus callosotomy. Fast polyspike, 4 to 6 Hz, with early morning jerks, is juvenile myoclonic epilepsy. And avoid carbamazepine and phenytoin, which make it worse. West syndrome is the infant triad: spasms, hypsarrhythmia, and regression. And Gelastic laughing seizures with precocious puberty means a hypothalamic hamartoma. B. West syndrome, linked to tuberous sclerosis in about 1/5 of cases, and treated with steroids or vigabatrin. C. 3 Hz is absence. Lennox-Gastaut is slower, 1.5 to 2.5. Juvenile myoclonic is faster, 4 to 6. B. Lennox-Gastaut. And those drop attacks are the classic indication for corpus callosotomy or vagal nerve stimulation. B. Juvenile myoclonic epilepsy shows fast 4 to 6 Hz polyspike. And remember, carbamazepine and phenytoin can worsen it. B. A hypothalamic hamartoma, gelastic seizures, precocious puberty, and developmental delay. Fourth idea, the EEG itself. The normal background, alpha 8 to 13 Hz, sits posteriorly with the eyes closed and blocks the moment the eyes open. Beta is frontal. 2 named abnormal patterns: hypsarrhythmia, the chaotic, high amplitude, multifocal mess of West syndrome, and burst suppression, alternating bursts, and electrical silence, which is your titration endpoint for a barbiturate or propofol coma. And know your electrodes: depth or stereo EEG. Electrodes sample deep structures in 3 dimensions under stereotactic guidance, whereas the subdural grid maps the surface but needs a craniotomy. B. Alpha is posterior and symmetrical, with the eyes closed and blocks on eye opening. Beta is the frontal, faster rhythm. B. Hypsarrhythmia, the interictal hallmark of West syndrome. B. Alternating bursts and electrical silence mark the depth of a pharmacological coma, used in refractory status and for neuroprotection during temporary clipping. C. Depth or stereo EEG. Electrodes give 3-dimensional deep sampling. Subdural grids map the cortical surface, but need a craniotomy. 4 ideas carry the whole diagnosis half: 2 seizures to diagnose, 2 failed drugs to refer. Semiology localizes the focus: temporal, frontal, occipital, each have a fingerprint. EEG frequency names the syndrome: 3 Hz absence, slow Lennox-Gastaut, fast juvenile myoclonic. and know your normal alpha and your electrodes. Diagnose cleanly, and the surgery comes easy. Next, part 2. Managing the epilepsy and working the patient up for surgery. The drugs, status epilepticus, the lesions that cause epilepsy, and the pre-surgical investigations. If this made epilepsy feel smaller, subscribe, and I'll see you there.